Everyone. We are really glad to have Dr. Patti Katz with us today. Many of you probably know her. Dr. Katz, I think, is maybe sort of retired, but not really retired from UCSF, where she is a professor, maybe emeritus. I'm not sure if that's your official title, but sort of kind of in retirement, but still definitely around and doing a lot of great things. She's in medicine, does work in medicine and health policy. So many of us know Patti from American College of Rheumatology or Association of Rheumatology Professionals, where she's been really active in a lot of different roles, including a lot of mentoring and training and research. And she's been editor of multiple journals and just has had a really big impact there and has done a lot of work in areas like physical activity and sleep, and is going to talk to us today about sleep in the context of both lupus and RA. And so we'll go ahead, and I think we'll have some time at the end for questions, but if you have questions you want to put in the chat during, I think that's fine too. All right, Patti, it is all yours.
Okay, thanks, Callie. I'm happy to be here today. And I will tell you that I'm not going to be able to talk and monitor the chat. So if somebody has a burning question, just speak up and interrupt me. And that's good. Or we can just wait to the end, whatever works. So as Callie said, I'm going to be talking about sleep today. So just to give you an overview of what I'm going to cover, why we should look at sleep, some types of sleep disorders this is not all sleep disorders, but the ones that I'm going to talk about, just give you the background on those, how we're measuring sleep disorders, and then switch specifically to what we know about sleep disorders in rheumatoid arthritis and lupus, and then talk to you about my current research. So the first one, why should we sleep? Sleep has some really important functions, and I'm sure on the days that you haven't slept well, you will know some of these. You'll feel them. Sleep is important for mental and physical restoration. It lets our bodies repair and regenerate and recover. It helps consolidate memories, regulate hormones. It's really important for learning and cognitive performance. It improves attention and creativity, and it does improve memory. It's important for mental health, and it's important in immune system regulation. Some of the effects of insufficient sleep are particularly relevant to rheumatic diseases. You'll see as we go through this list, things that are common and are often studied in both RA and lupus and other rheumatic conditions: depression, cognitive impairment, lower pain thresholds, higher cardiovascular disease risk, weight gain, diabetes, and impaired immune function. So you can see why all of these things might have relevance in rheumatic diseases. There are many types of sleep disorders, but I'm only going to talk about the ones that I'm just going to discuss today: fragmented sleep, obstructive sleep apnea, restless leg syndrome, and short sleep. So fragmented sleep is exactly what it sounds like. It's when you wake up one or more times during the night, the time that you're awake can vary from just a few seconds, where you may not even realize it, to hours. There are a lot of causes from that. It can be from some other sleep conditions like obstructive sleep apnea or restless legs, the need to go to the bathroom, pain, hormonal reasons. Menopause is notorious for causing fragmented sleep. Stress, I'm sure we've all been up in the middle of the night worrying about something. One of the impacts of fragmented sleep is it reduces the overall amount of sleep that a person can accumulate, and it also affects the type of sleep. Obstructive sleep apnea, the physicians in the group are probably acquainted with. It occurs when there's this is a normal airway. But you can see in obstructive sleep apnea, the tissues in the tongue can relax back against the throat, and it blocks the airway. So it can be a partial blockage, which would be called hypopnea, or it can be a complete blockage, which would be apnea. And the apnea-hypopnea index is how obstructive sleep apnea is graded. And it's usually the cut point between mild and moderate is usually what's looked at. There are some related measures to obstructive sleep apnea. Oxygen desaturation index is one of them. So that's the number of times per hour that blood oxygen falls for more than 10 seconds. There are some known risk factors for sleep apnea. Older age, male sex, obesity, and smoking are some of the primary risk factors. Obstructive sleep apnea is often undiagnosed, but it can be treated if it's diagnosed. The estimated prevalence is lower in women than it is men. So you can see here, these are some sort of population averages of 3 to 8% in women and 12 to 15% of men. Restless leg syndrome is this irresistible urge to move your legs when you're lying down. It's just like you have to stand up and move, and you can get all sorts of weird feelings in your legs, and it's just really uncomfortable. As you can imagine, that can make it difficult to fall asleep. The prevalence in the general population is estimated to be somewhere around 15%, but there's not really great data about this. And then short sleep. The CDC defines short sleep as less than 7 hours a night. Sleep research is usually looking at shorter times, like maybe less than 6 hours. I've even seen less than 5 hours. The prevalence in the population is higher than any of the other two sleep issues. Less than 6 hours is around a quarter of the population. And then less than 7 hours is a little over a third of all of adults. And the prevalence is a little lower for older adults. So I'm going to talk a little bit now about how we measure the sleep conditions that I just mentioned. You see here a picture of the output or illustration of polysomnography, which is the gold standard for measuring sleep. And you can see you've got people with the cannula in their nose, and you've got things hooked up to your head, and the band around your chest and your waist, and the sensor on your finger here. And this would be done in a lab setting. And while that's the gold standard, it can be cumbersome. There are some people who would say it can diagnose important sleep disorders, but it also is not measuring people and their daily lives. So there's some advantages to home-based monitoring, which might be actigraphy, and there are other home-based methods. There are also some validated screening measures for the two conditions I talked about, obstructive sleep apnea and restless legs. And there are a whole bunch of subjective measures of sleep, self-reported measures of sleep quality or sleepiness or the impact of sleep disturbances. Actigraphy this is an illustration of an actigraph. It's worn like a watch on the wrist when it's measuring sleep. It has, most of them have been validated against the polysomnography for sleep-wake patterns. The primary measures that we've used from the actigraph is sleep efficiency, which is defined as the time that a person is asleep divided by the time that they're in bed. And so normal sleep efficiency would be 85% or higher. Wake after sleep onset, or WASO, is the time that a person is awake during the night after sleep onset. So in a way, it's a measure of sleep fragmentation. And then it's also possible to get daytime activity or napping from the actigraph. Scoring of an actigraph is usually improved with the use of a sleep diary, so people can record what time they went to bed, what time they got up, and that kind of thing. It's also a good opportunity to collect other kinds of information, like pain during the day and pain at night and that kind of thing. Obstructive sleep apnea home monitoring. There are several devices that can be used. This is the one that we use. It's called a watch pat. And you can see this device here. It fits over a finger, so it works like a pulse ox in a way. And then there's a device. This piece goes on the chest, and people wear that for a couple of nights, and you can get a good measure of the apnea-hypopnea index, so you can get get an assessment of sleep apnea. You can also get other measures like the oxygen desaturation index, and you can get sleep staging. And then it's also been validated against the PSG. Excuse me. So moving into the screening measures, this is a screening measure for obstructive sleep apnea called the stop bang. And you can see here that oops, didn't mean to do that. You can get, you get points for each of these: snoring, tiredness during the day, having someone observe you stop breathing during sleep, high blood pressure, high BMI, older age, neck circumference, and male sex. This is the screening question for restless leg. Both of these have been validated. When you try to relax in the evenings or sleep at night, do you ever have unpleasant, restless feelings in your legs that can be relieved by walking or movement? And then there are, as I said before, there are a whole bunch of self-reported sleep measures. Probably the oldest is the Pittsburgh Sleep Quality Index, but there are others. The Medical Outcome Study has a sleep scale. The Upward Sleepiness Promise has a couple of sleep measures deployed in its suite of measures as well. So now I'm going to turn to RA and lupus specifically. So what do we generally know about sleep in RA? What is the existing research? So we know that self-reported poor sleep is quite common, but studies using objective measures of sleep have been uncommon and small in the past. The ones that have been done, though, have shown pretty high rates of poor sleep efficiency and high levels of sleep fragmentation. OMERACT has recognized that sleep quality is important and has said that sleep quality is a priority area for improving the health of people with RA. Specifically about OSA, there have been some small PSG studies that have found really high rates of OSA in people with RA, but these have mostly been done in clinical sleep medicine settings, so the rates may be exaggerated just because of the people that are showing up to get the tests. Screening measures have shown lower rates of around 35%, but those are still significantly higher than what's seen in the general population. Restless leg syndromes, there have been several studies of RLS, and those are showing estimates of about 25% in people with RA. And then short sleep, the findings are mixed, so not really coming down on one side or the other of whether it's more prevalent or not. But there is one study that's found short sleep duration is causally linked to an increased risk of RA. Sleep disturbance, though, is likely to have both some unique causes and unique consequences in RA. And pain thresholds is one area where that might be true. Pain can cause sleep fragmentation. So if people are uncomfortable, they're in pain, they wake up a lot, they can't go to sleep well. And conversely, sleep disturbance can lower pain thresholds. So you can see that there's sort of a vicious cycle of sleep disturbance that might happen here. This study by Michael Irwin is a good example of that. They created a study where they had a partial night sleep deprivation of a group of people with RA and a group of people without RA. And you can see here, these are pain levels. So this is the control group, and they kept people up They kept people up during this period of time where they would normally be asleep. And then people went to sleep, they woke up in the morning. And you can see there's a little bit of a rise in pain ratings here, but it's not particularly big. The people with RA, though, as you might expect, had higher pain ratings before sleep, but then they had this big spike of pain ratings after the night of sleep deprivation, suggesting that they were more sensitive to sleep problems in their perceptions of pain. There's also some immunologic factors that demonstrate the unique aspects of sleep, the relationship of sleep in RA. So there are cytokines that play important roles in RA, also play important roles in regulating sleep. And it's pretty well known that sleep disruption leads to increases in inflammation in general. And just to use IL-6 as an example, in RA, the circadian cycles of IL-6 have greater variability, and the peak levels are greater, and they occur later in the morning. And that shifting in IL-6 tracks with the peak levels of pain and stiffness in the morning. So this is an example of this. The black lines are it demonstrates the circadian cycle of IL-6 in people without RA. The red line shows you this big spike that is very early in the morning compared to when the IL-6 levels are dropping in the control groups. And as you can see, there's some dysfunction in this same cycle in people with insomnia. So again, this graph with the graph with the solid line shows people without insomnia, and the dotted open circles shows how these elevated levels of IL-6 in people with insomnia. So now I'm going to turn to my own research in RA and sleep. So this first paper is published from the forward cohort, which is a very large cohort of people with RA. And in one, data are collected with semi-annual questionnaires or interviews. And in one interview, we added the screening measures that I showed you earlier, the stop bang and the RLS screening measure to the questionnaire. So what we looked at was the prevalence of short sleep, the risk of obstructive sleep apnea, RLS symptoms, diagnosis of either OSA or RLS, and then looked at the factors associated with each. So just to give you a little picture of the cohort, you can see it's an older cohort, primarily female, as you would expect with RA, primarily white. People do have, there was a, excuse me, fairly large percentage of obesity, and with variety of comorbid conditions. And there were about a third of the group was currently using steroids. So about 10% of the group was identified as high risk for OSA, 18% reported a diagnosis. And if we look at either high risk or diagnosis, it's 21%. And if you remember back to the numbers I gave you earlier, that's considerably higher than the estimated prevalence in the population of 3 to 8% of women. RLS symptoms in 28%, a diagnosis in 13%. So if you combine those two, 30% either RLS or, oh geez, keep hitting the button, sorry, are either diagnosis or symptoms. And short sleep, if we look at less than 6 hours, it's a pretty high percentage, close to half. And if we look at less than 7 hours, it's almost 3/4 of the people were reporting short sleep of less than 7 hours. So what were the factors associated with sleep? There were a variety of things that you might expect. But the important thing for this conversation is that both the RADI, which is a measure of self-reported disease activity in RA, and pain ratings were each significantly associated with each sleep disorder. Medications, I think we would always expect that glucocorticoids would be associated with poor sleep. And in the unadjusted analyses, they were adjusted with obstructive sleep apnea, but in the multivariable analyses, they were not. And then there was this sort of odd association of abatacept with a lower likelihood of RLS and short sleep. The limitations to this analysis, though, is this is an older cohort. It's over 90% white, they're well educated, and these are all self-reports. So take-home messages from this analysis were that sleep disorders were common. They were present in almost 2/3 of the sample. Percentages of people with each condition were considerably higher than we might expect in other situations, other population averages. RA-specific factors played an important role in each. What we don't know from this is whether sleep disorders cause or amplify existing RA symptoms, or whether the symptoms are somehow involved in the sleep disorders, arising, and that might be particularly true for short sleep. Glucocorticoids were not associated with the disorders, which was a surprise. But considering that we adjusted for disease activity, and other factors, that may be why we weren't seeing that. And I don't really know what to do with this associated with abatacept. And if any of you have suggestions, I would like to hear that when we move to the conversation part of this. So next, I'm going to talk about my sleep study that we did here with objective sleep monitoring. We call that RAS. The study aims were to objectively look at the prevalence of sleep disorders, the risk factors, and then some effects on health outcomes. And we were also looking at this IL-6 pathway that might be unique to RA to explain the high prevalence of sleep disorders. So this was the intended design. We had a baseline. People were going to come in, get their blood drawn, get a physical exam, so we could do disease activity measures. They were going to go home. They were going to do 3 nights of pulse oximetry with the WatchPat, 7 nights with the actigraph. We were also doing salivary cortisol measures, and then they were going to come back on day 10, not day 7, to do morning blood draws. And then we were going to have a follow-up assessment or 2 follow-up assessments at 6-month intervals, where that would be repeated, except for the oximetry, and then 2 more follow-ups that would just be actigraphy and questionnaires, and we would mail those out. So that was the plan. What really happened is sort of important in research because things often don't go as planned. Our funding was cut initially, so we immediately dropped that 4th follow-up, so we could actually do the study within our budget. And then COVID happened. So when COVID happened, people couldn't come in anymore because, as you did, we had a research shutdown. So we had to shift everything to complete remote. So we were mailing out actigraphs and doing phone interviews, but we're not doing the oximetry monitoring anymore. We weren't getting any more blood draws, which is a shame when you see the results that we didn't have better data there, but we did keep the study going. So participation, our goal was to get 150 people. We got 133. We got valid actigraph measures at baseline from 116. We only got 63 WatchPats. We got blood samples on a minority of them at different points, and we had physical exams. So when I show you the data, you're going to understand why the the numbers of people that have CDIs, for example, is lower. This, I think, is one of the most clinically relevant findings, that over half of the cohort, and granted, it was only 63 people, but over half of them had moderate to severe sleep apnea on monitoring. And importantly, the screening measure didn't work very well. So you can see of the people who had severe sleep apnea, they were not being consistently picked up by the screening measure. And if we look at people who had ever been diagnosed, there's a little bit better correspondence, but still only 50% of them were showing up. So there's a lot of undiagnosed and unrecognized sleep apnea in this group. You know, the question of why the correspondence between the screening measure is not particularly good here. It's primarily a female sample. And so since OSA is more prevalent in men, that might have something to do with it. We didn't measure neck circumference, which is part of the stop bang. And we didn't measure blood pressure, but we had people report if they had been diagnosed with hypertension or were taking medication. And then the fatigue is part of the stop bang, and there's such a high prevalence of fatigue and RA that might have something to do with it. But I think the key issue here is that we're not seeing good correspondence between the screening measure and the actual results. We did see some association and suggestions of associations with some disease markers with OSA. You can see here that the mean IL-6 levels were significantly higher in people who had moderate to severe OSA, and it looked like ESR was going in that direction, but again, with this small sample size, it's sort of hard to know. So switching to the actigraphy results, at baseline, if we're looking at sleep efficiency, less than 85% is the key marker. We have about half of the people at baseline showing poor sleep efficiency. If we look at all 4 periods, 70% had poor sleep efficiency at least one measurement period, and about 40% had poor sleep efficiency at each measurement period. We didn't see, again, a great deal of association with the clinical measures. There's this hint here. I mean, we see this higher CDI here with people who had less than 85% at any point. And we also see the difference in the radii. So again, with the small sample size for these measures, it's hard to know what if our non-significant results are really no association, or if this is simply a power issue. Overlap, 35% had both low sleep efficiency and short sleep, and 30% had neither condition. If we look at the WatchPat cohort, then we can see that 22% had all 3 conditions, this group in here, and only 5% or 3 people had none of the conditions. Okay, so now I'm going to switch to lupus. So what do we know in general about sleep and lupus? Again, self-reported sleep disturbances are common. There have been, at the time I made these slides, there were only 2 small cross-sectional studies using objective measures. And again, they showed high rates of sleep disturbance. And short sleep has also been linked to the onset of lupus. This is a graph from that study that shows it was a Taiwan National Health Insurance data. And so they looked at people who had some sort of sleep disturbance that was not OSA. And you can see the control cohort, there's a significant increased risk of development of lupus for this group of 1.8. The hazard ratio for comparison in RA was also significant, but not quite as high. So I'm going to talk now a little bit about my data in lupus and sleep. So the first results I'm going to show are from our CLUES cohort, which is a longitudinal cohort study based in the San Francisco Bay Area. We start that off. We have initial in-person visits, and then we follow with annual phone interviews. We use the same screening measures in one of the interviews, one of the CLUES interviews, and we found that, again, these high rates of OSA and RLS, most of them were diagnosed with were identified as symptoms. Fewer had been diagnosed, but again, it's a little over a quarter for both conditions. Then turning to the lupus sleep study, this is a DoD-funded study. We had 61 people who were CLUES participants who participated in this study with objective sleep monitoring. We had 2 measurements of folks. They were about 10 months apart. So this is what this cohort looks like, sort of what you would expect in terms of the sex distribution. About 40 years old. We did have some diversity in the sample. And then we have a variety of comorbidities here. And these are people who had duration of about 15 plus or minus years. So this study is still, I'm still working on the analysis here. So, but if we look at, this is all from the baseline data. almost 75%, 74% had sleep efficiency less than 85%, which is really high. If we lower the sleep efficiency criterion to less than 80%, we're still showing 39% had poor sleep efficiency. In terms of short sleep time, almost 2/3 of people were sleeping less than 7 hours, and a good quarter of them were sleeping less than 6 hours. You can see this is looking at the SLEDI disease activity and the SDI disease damage. And there's a hint here that there's some sort of association with sleep disorders. You can see that the damage index here is higher for people with obstructive sleep apnea. And if we look at poor sleep efficiency, we're seeing higher both disease activity and disease damage. The caveat here is that the SLEDI and the SDI weren't conducted concurrent with actigraphy. We're working on trying to get better estimates right now. Again, this is another COVID affected study. We had intended to have people come in so we could get blood draws and do at least the SLEDIs in person. But people were still not coming in for research studies. So we're trying to go back to medical records and cobble together a good estimate of the SLEDI and the SDI at the time of these visits. So summarizing all of the data that I've given you, this is first for RA. You can see here that the purple bars are the population averages. In forward, we have a slight increase of OSA. In RAS, where we actually measured it, we have a really big difference here. This, in reality, is for the forward is probably higher if we were measuring it, but this is just with the screening measure. RLS, again, much higher rates. If we look at short sleep less than 6 hours, we're not seeing that much difference here. But if we look at short sleep less than 7 hours, we are seeing that there are very large differences in the proportion of people who are reporting short sleep. And this is just the prevalence of low sleep efficiency. We don't have a good population comparison there. For lupus, again, we have the population is the purple, and you can see that OSA is much higher. We see a slightly lower slightly less elevation in the lupus sleep study, and this is, I think, primarily because this group is younger. RLS, much higher than the population. Short sleep, less than 6 hours, not much difference. But again, if we look at less than 7 hours, we do see a pretty big elevation. With disease status, there are some hints that sleep disturbance might be linked to disease activity in both RA and lupus. In RA, there's a suggestion that this IL-6 link may be present and may be important. But the samples are small. We had limited diversity in disease activity because, as I'm sure you know, people don't come in for research visits when they're not feeling well. And so, yeah. So just a quick little side note of the association between these objectively measured sleep metrics and the self-reported sleep measures. I mean, the short answer is there's not one. And this was sort of disappointing and shocking. If we divide people by sleep efficiency, less than 85%, yes, no, you can see on these measures of the Epworth sleepiness, which not many people are using, but people may be using these PROMIS metrics, nothing, no difference. If we change the sleep measure to less than 80%, again, we're not seeing anything significant. Again, the sample sizes, particularly in lupus, are a little on the small side, but there's nothing. Short sleep, less than 7 hours, we're not really seeing anything. And if we look at less than 6 hours, we're starting to see maybe in lupus, there might be a difference. I mean, these numbers, they're not necessarily significant, but we are seeing at least differences in the right direction. I don't know what this means for us when we're trying to use self-reported sleep measures to do research, but I think it's something that we need to spend some time thinking about. So overall, take-home messages, objectively measured sleep disturbances are more common in both RA and lupus than in the general population. There's this evidence of relationship with disease activity in RA, which is especially true for obstructive sleep apnea. IL-6 may be implicated. In lupus, there's a suggestion of a relationship with disease activity and damage. Importantly, for those of us who do a lot of PRO work, the PROs that are commonly used to measure sleep problems don't correspond to the presence of objectively measured sleep disturbances. So I think that we're left with more questions than answers here. And I really look forward to hearing your thoughts on where things might go next. So thank you for your attention. I'd like to acknowledge my funding for RAS. I had an R01, lupus sleep study is funded by DOD, and CLUES is funded by the CDC, and then all my collaborators. So I'm going to stop sharing now. And I guess I'll open up the chat. So thank you.
Thanks, Patty. That was great. I haven't seen any anything in the chat box, so people can just go ahead and unmute and ask questions.
I have a question, Patty. I think we had spoken about sleep diaries at some point and looking at associations between sleep diaries and the more objective measures and actigraphy, and was just wondering if you guys had a chance to do that yet.
I didn't do the scoring on the actigraphs. We have a sleep epidemiologist here, and her team did that. When they initially gave me the sleep data, they just gave me the average for the measurement period, and I just recently got the daily data, so it's there. So I haven't looked at it yet. I gotta say, and we also don't have I don't have the questionnaires at each day, but I do have single item, how did you sleep kind of thing. So we'll see. I'm not optimistic.
So we actually did look in our data for RA with
And
a
what did you find?
small population, 50 patients. So sleep duration, we found a 0.6. We only did, bivariate associations. We didn't do any adjustments, but we found a 0.6 with sleep duration, a 0.45 with sleep onset latency, and then a 0.3 with WASO. And the sleep efficiency was like totally
Correlating with what?
basically sleep duration on diary versus sleep duration on actigraphy.
Oh, you're talking about the accuracy of self-report.
Yes.
Yeah. Yeah, I mean, we have a single item measure of how well did you sleep. So we can look at that, but I think that's sort of like the equivalent of a single item PRO of sleep quality. So I don't know. So I'm sorry, you got high correlations with what were the
I
two?
wouldn't say they were high.
Well, 0.6 when you're dealing with people is pretty high.
0.6 for sleep duration. So basically, we were like measuring directly like sleep duration based on diary. So
Okay, so self-reported sleep duration
on actigraphy directly. Yeah. So yeah, those kinds of measures. The 0.6 is the highest we got. Like the others were like 0.45, 0.3, or even less.
Yeah, nothing to write home about.
Yeah.
So we'll see.
It does beg the question.
Yeah, it does. I think with lupus in particular, people have had poor sleep for so long that they don't actually recognize that they're having poor sleep. Because if you looked at the mean scores, they were like at the population average for PROMIS. They were all hovering around 50. So anyway, So Lee, I see you've got your hand up.
I think Richard may have had his up.
Oh, sorry, you're first in my screen. So Richard.
Thanks, that was interesting. And I'm particularly interested in the IL-6 connection. And do you think that's just a measure of systemic inflammation, or is there anything known about IL-6 and the sleep centers within the brain that kind of control wake and sleep, and whether or not IL-6 is actually acting at a central level as opposed to just being a marker for inflammation?
Well, you know much more about IL-6 and immunology than I do, so I'm going to give you a fairly uninformed answer. But some others who have better knowledge, I hope you'll chime in. I think that it's particular to IL-6. I don't think it's general inflammation, because if you saw those differences in the circadian rhythms, I think that we're seeing something that looks sort of like the disruption that's seen in insomnia, but looking at some of the other curves, they didn't look that different. So I don't know. I think it's IL-6 specific, but I don't. Others might have other thoughts. I don't know. What do you think? You know more about this than I do.
I know a little bit about IL-6, but not about the brain connection to IL-6. I haven't actually looked for that to know if cytokines, could affect sleep at the CNS level. So that's just, but thanks for the talk.
Yeah, thank you. Okay.
And I think you had a question about the abatacept. I mean, unlike the other D modes, DMARDs, I'm thinking about D modes because I'm writing something else on D modes. It doesn't directly inhibit cytokines, it inhibits T cell activation. So I don't know if some of the other biologics that directly block TNF, for example, or IL-6 would have a different kind of effect because of that.
Yeah, we didn't see a signal for TNF inhibitors. I didn't see a signal for, is it tocilizumab that targets IL-6? Didn't see that, which I sort of expected. Although again, we didn't have that many people that were on the meds. So yeah. Anyway, Lee.
Do you have any data, Patti, about, or does other people have data about, I get information about my poor sleep on my watch and how the Apple Watch and I don't know if Fitbit does sleep, how that, translates to the actigraph and measuring sleep.
I've seen a couple of studies. I see Yvonne smiling though, so I'm wondering if you know anything. I wouldn't use an Apple Watch for research purposes, but I think the devices are getting better. I don't know, Yvonne, since you're smiling, I think
No,
you
I
know.
was only thinking about my own Apple Watch and how I doubt what it's telling me. That's why I was smiling.
I have terrible sleep according to my watch.
Well, I just remember hearing stories about you sleeping 4 hours a night too. So there's that.
Oh, well, I think I do, but I'm in the bed much longer.
Yeah. All right. Yeah. So I think it's an interesting area, and it certainly would be easier to sort of download those big caches of data, but I don't think, and I have seen some studies that were trying to validate various commercial devices, and the results have been sort of mixed. So, yeah. Louise? Hi.
Hi. We talked at ACR a bit about how I'm currently in the middle of interviews and sleep keeps coming up in patient interviews for research. And one that I just recently did this week, the person was extensively describing their sleep aids, and what they do to try to get a good night's sleep. And so I was wondering if through any of the data sources or the work you've done so far, if you've seen any information on sleep aids or gathered any of that.
So we did, in our interviews, we did collect information on whether people were using prescription sleep meds, non-prescription sleep meds, other sort of like supplements that they might, that might help. I haven't done anything with the data. But I have it for RA and I have it for lupus, and they're both small cohorts, but I do have it. We actually have a little more data for lupus from the clues. I think we had something. So, if you're interested, we can talk. I'm always happy to share data because God knows I don't have time to look at everything I want to look at.
Patti, I'll ask you a question. This is a little bit broad, but if you could pick like 1 or 2 or 3 things that you think would be most important as next steps in kind of moving this forward, what might those be? Like maybe some more intermittent steps related to measurement or screening, or like ultimately, what do we do to improve care? What do you see going on in this research area, and what do you think needs to happen that's not happening?
So I think that that high rate of obstructive sleep apnea and RA, I think, was probably the most immediately actionable. Mm-hmm. That study probably needs to be repeated, but that, I think, there's some known poor health effects of obstructive sleep apnea. So I think knowing that and knowing the high rates of fatigue in RA, that and the high rates of cardiovascular disease, which is associated with OSA. I think that that's probably something that deserves some recognition. As a person who spends a lot of her life thinking about PROs, patient-reported outcomes, I'm sort of troubled that we don't have either good screening measures or good PROs where we can sort of estimate what's going on. So I think that is something that needs some attention. Mm-hmm. And then in general, since we're seeing such high rates of short sleep, I think probably there needs to be an emphasis on the importance of good sleep for health, for all of us. But I think that people with rheumatic conditions may have particular influences on their health by not having sufficient or adequate sleep. But I don't know, I'd appreciate comments from some of the clinicians, and I see Beth has her hand up, so maybe you'll be the first one.
Yeah, so I'll just share some thoughts from the clinical side of things is, from the perspective of, a rheumatologist, I think having sleep front and center when you're seeing patients is maybe the first step to be thinking about it. But I will say that in my practice, I will go down the pathway of asking about sleep, mostly when patients describe fatigue or, so fatigue is usually what patients will come with. They won't always say, I'm not sleeping well. So they'll say, I'm tired, I don't have enough energy, I can't do what I want to do. I get to 5 o'clock and I got to get back in the bed. The next question has to be, well, what is your sleep like? And I will tell you that even patients who I've ultimately diagnosed with severe obstructive sleep apnea who required intervention often did not say that they weren't sleeping well. Their partner sometimes says that they're not sleeping well, like they snore or they're kicking all the time or they're very restless in the bed. But sometimes patients, and that sort of fits with some of what you showed, was that the patient reported outcomes, as a marker are not nearly as good as those objective measures that you're seeing in the lab. Now, I don't think everybody necessarily needs to go to the sleep lab to be looking for this, because I think that doesn't make a heck of a lot of sense. But when you start to identify these themes, and the other thing I will say is that, disease activity in RA is associated with poor sleep, but I'll also say that you control the disease activity, right? You bring down those levels of cytokines, you control the degree of synovitis. The sleep disturbance often persists. And those patients will often come with a clinical phenotype that looks a little bit more like fibromyalgia, where they have muscular tenderness and not synovitis. And that's another clue where we feel like the sleep may be what's driving that sort of pain phenotype. So I think it's really, really complicated, and it's not just about disease activity and cytokines and inflammation. I think that the poor sleep in and of itself begets this sort of generalized central pain syndrome that we see in about 30% of patients with RA and lupus.
That's an interesting perspective. Yvonne, you've done some work in centralized pain. So do you think there's a role of poor sleep in leading to centralized pain? I think it's a really interesting issue that Beth brings up.
No, absolutely. I think we've done some studies, like in CATCH, the early arthritis cohort, where we've looked at sleep disturbances predicting pain like a year later, and it does predict pain a year later. It predicts pain interference a year later as well. We've also been trying in our cohort, our very small 50-person cohort, to look at associations between sleep disturbances and like more of the pain sensitivity measures or the quantitative sensory testing measures. And in univariate or bivariate analysis, we've seen associations with temporal summation of pain, which is thought to be one of the mechanisms of fibromyalgia. It goes away in the multivariable analyses, so hard to say there, but we have a very small sample size as well and other limitations in the study. So I would say I completely agree with Beth's thoughts, and I definitely believe something's there. I just need to probe it more.
So I don't know. Has anybody looked at sleep disturbances as a precursor to or a risk factor for development of fibromyalgia, or is it all just and what have been the
I can't point to papers, but I think it's well established that poor sleep in and of itself is a risk factor for the development of centralized pain, fibromyalgia, soft tissue rheumatism, whatever you want to call it, right? I think that's very well established.
Yeah, I know that there's an association, but I didn't know the research about the risk.
I don't know if there's one like specifically looking at sleep disturbances and then an incidence of fibromyalgia later, but there's definitely stuff with like pain, like increased pain.
Yeah. Well, and that makes sense with the increases in the decrease in the pain threshold, particularly. So, anyway. So I see that we're almost at the half hour. So I want to not persist in the conversation, although it's interesting.
Yeah, well, thank you, Patty. And I see Richard has something in the chat for those who want to look at it, a
Oh,
review
great.
paper.
Thank you.
Go ahead,
It's just
Richard.
a really extensive review paper I just found that looks at all the different mechanisms by which the innate immune system and IL-6 and other cytokines affect sleep, including a section about how they affect the blood-brain barrier and the regions of the brain itself that are involved in sleep. So it looks like there is a central connection.
Okay, that's Michael Irwin. He's done a lot of work in sleep and inflammation, and he's worked with some folks in rheumatology as well. So that one study I showed of the partial night sleep deprivation was his. So thank you for pointing that out.
Sure.
Well, thank you again, Patty. It was really, I thought, helpful to see this summary on this topic, including your work, and we appreciate your time and the great conversation.